this meeting to order, and we'll start with, I believe, housekeeping.
Housekeeping. Can we have the agenda? I have the agenda here. Let me open it. Okay, so housekeeping. We are going to be, I guess the first item is that we are recording the meeting. So we've officially started the recording, okay?
Okay.
So, just so everyone's aware. And then a few things were updated for July 1st that we wanted to remind the group of. And the first was that on July 1st, you recall back, I believe in February and March, we reviewed stimulant medications for ADHD. And we implemented our first set of safety edits for using ADHD stimulants in children. And we did this with implementing a lower age edit. So the review that we covered in the guidelines looked at use in children less than 4, and the board recommended a PA for any child less than 4, unless the product labeling indicated that use was 6 and under, or under 6 years of age, was not authorized. So PA was implemented for that as of July 1st. And I believe we had four children who were would have been infected by that edit. So we did the typical like peer-to-peer outreach, letting the providers know that this was starting on July 1st and getting a PA in place. Coming up on August 1st, however, we do have the second round of edits that will be implemented. And this was concurrent use of stimulants in children or adults. So this was using different classes. So whether if a person had amphetamines and methylphenidate at the same time, it would limit utilization of those 2 different classes for more than 30 days. So it allowed a cross tapering, I believe, for, even though we knew there weren't cross tapering, we were allowing that window of it, one script running out and another script being started. So there will not be allowed to be concurrent use of amphetamines and methylphenidates. We also limited utilization of 3 or more agents within the specified drug class. So if you were getting a short acting and a long acting, there would be no more than that allowed within one class, and that's across all ages. And then just as an update, we implemented our final opioid MME edit, looking at 90 MMEs at the top end, or I'm sorry, the top threshold of what would be permitted for all opioid prescriptions without a prior authorization. And a CMS meeting maybe 2 weeks ago, they're looking at acute prescriptions now for pain, and having plans consider a lower threshold for acute use of 50 MMEs. So that may be coming in the future, but that's just up for consideration and discussion right now, and was put out there by CMS. With that, I think those are the housekeeping minutes.
Okay, great. Thank you, Jen.
You're welcome.
All right. Next item is the review and approval of the minutes from our last meeting. Are there any changes needed?
I would move to approve.
I'll second.
All right. All those in favor of approving the minutes, say aye.
Aye.
Aye. Any opposed? Abstentions? All right, the minutes stand approved. Okay, next item on our agenda is the P&T committee update.
So in June, the P&T committee met, and we had our annual Open Public Meetings Act training with Tony Patterson, and we also discussed acute treatments for migraines, so all the abortive treatments with a focus on the CGRP antagonists, the lasmiditan and just the newer agents, but we did discuss all of the abortive treatments. And next month we will be discussing biologic treatments for asthma. So, or not, yeah, in August. No, September, sorry.
Perfect. Thank you. All right, so the next item on the agenda is, I believe, our own annual training. Is that correct? For Utah Open Public Meeting Act?
Yes. Hello, everyone. This is Tony Patterson. Thank you, Brian, for that reminder of last month or at the P&T meeting. After the presentation on the Open and Public Meetings Act, there was a discussion on migraines. I found that humorous, so this is now your opportunity. Perhaps you want to have the opportunity to discuss migraines afterwards. I think this is a very fascinating time because of the continual changes that we have regarding, and I don't know if everyone can see what I'm presenting.
We see it, Tony.
Okay. So the purpose for this training is that it is a helpful reminder. And of course, it's mandated by the legislature. So it's something that no one asked for or no one has an opportunity to have a choice on. It is required. And as we have continued as a government to adjust electronically, we've had the opportunity to adjust to many things with the Sunshine Act. Over the years, we continue to have to make adjustments. And this particular year, we've continued to make adjustments electronically, but we came across something new that our act was totally unprepared for. And so one thing that is refreshing about the presentation this year, there are substantial changes to the act which just took place that I will briefly go through that was precipitated by the COVID-19 pandemic. So we know why the legislature wants us to do it, because it is so easy to forget about the act. It's easy to overlook it. Now, keep in mind that the House and Senate also have to have their own annual training. So this is something that they go through as well too. Despite that annual reminder that they imposed upon themselves and upon all of us, I found it interesting that they themselves innocently, and I believe without any ill intention, violated the own act, their act, which they passed. There was an article back on April 6th, and so that was more at the beginning of the pandemic. Our Speaker of the House called together an electronic meeting of all of his 74 colleagues. The problem is that he did not have public notice. The problem was there was not an anchor location where the public notice had to be posted. There was no opportunity for the public to hear, to listen. And because of that, there were technical violations of the act. So even though, this is something that we have reviewed annually for many, many years, there's still the potential for violations. Now, what saved that particular meeting of the House is that there were no decisions made, so there was no need for a lawsuit to undo the decisions that had been made. Now, with the pandemic that occurred, there were changes that needed to be made immediately. And so one thing that was different this year is that back on March 18th, the governor issued an executive order. and he suspended many of the requirements in the Open and Public Meeting Act as it pertained to electronic meetings. So the requirements for public notice, the requirements for recording, the requirements of when closed meetings may be held, when emergency meetings may be held, there was still the requirement for notice for electronic meetings, to have an anchor location, and some of those things. Well, the government business would have stopped even electronically had there not been immediate relief from the act, because the act had not yet caught up to the changing circumstances created by COVID. So the governor first issued that executive order, and then on June 26th, the legislature enacted HB 5002, which implemented basically all of those requirements except for one that the governor imposed upon the government back in March. One exception that I would like to mention is that previously, under the governor's executive order, there was not a need for the head of the body to issue a written determination with findings that there would be a substantial risk to health and safety present if there was an anchor location. And so while the governor's executive order did not require this, this is now part of the law that is going to be going forward. So anytime that there is a substantial risk to health or safety, whether it be due to threats of violence, whether it be to future pandemics or other things which cannot be foreseen at this time, the Act now provides a way for the governing body, such as yourself, to continue to meet, to function. However, there has to be that determination made, and that determination is only valid for 30 days. So because of the pandemic, and as the government continues to adjust to it, there have been substantial changes to the Act just in the last month, and there likely will be continued changes that will be necessitated because of electronic means, or because of the electronic meetings as we become familiar with it. I appreciated the discussion prior to the meeting and the mention of the new normal. I don't know what the new normal is, because I don't feel everything has been normalized yet, but perhaps I'm on the out. I do point out that as the legislature met in special sessions this year, they actually passed two particular joint resolutions, one in the House, one in the Senate. And in both of those, there is directive to find ways in which electronic meetings can be better utilized to save cost, time, etc., for the government going forward. So these electronic meetings just may become the new normal. However, there are groups that are going to be studying it and making recommendations, and we look forward to future changes to that. So having said that, just as a reminder, it is important to not forget what is the purpose for, sorry, this is the one I'll be ending on. What is the purpose for the Open and Public Meeting Act? While there's not a lot of great risk of personal self-dealing with this particular committee and or board, excuse me, and thank you for your service to the public. We need to keep in mind that it is important to do everything we do in front of the public. And there is one change that we don't have any case law on, but I anticipate soon will be. And that is, we've talked about in the past about emails, texts, other things, instant messaging that were possible previously between board members during a meeting. We need to make sure that all comments made in the meeting are public and presented to everyone. And of course, the new one that we have this year is private messaging, which a lot of these formats, electronic meeting formats, have. Keep in mind that that is something that I would strongly advise against. Keep in mind your private emails. Keep in mind your private phone, if you're using it to text government business, can become subject to searches. Now, the penalty for violating the private or the Open and Public Meeting Act is a Class B misdemeanor. And I didn't see anyone rushing to pursue a Class B misdemeanor against our Speaker of the House when he violated the act. I think it's important to remember there is that potential. And while I believe the risk is low, I know that for myself, and I'm sure I speak for everyone, we don't want to be the first test case. We don't want to be the one to have that tried out on. So with that, keep in mind the purposes for it. Keep in mind the penalty. Keep in mind that everything that you do must be kept public. And as far as the other requirements of the act, the agency has done a great job in the past of ensuring that the other criteria of this annual training and the purpose of it and the purpose of the act is satisfied so that we don't trip up. But with that, thank you for your time. Are there any questions that any of you may have? Excellent. Oh.
Joe, you're breaking up a bit.
Could you restate the question?
Yes.
Perhaps you could use the chat function to ask the question because we're having difficulty hearing you.
While he's doing that, I just want to thank you, Tony. That is such a, I always love the training. I look forward to it. I think you present it in a wonderful way and it makes a lot of sense to me. Thank you.
Oh, thank you. You are kind. Joe, are you still going to present your question? That new standard, which just took effect June 25th of this year, is part of the decision that must be made by the, let me get the exact language. By the public body, the chair of the public body regarding holding an electronic meeting. So that is something that I'm happy to work with the agency and the board chair on to ensure that that portion of the act is satisfied. I don't believe it would need to be mentioned in the meetings, in the minutes, or in the agenda. I believe it would be necessary to include that determination in the written decision that has to be issued by the chair of the public body. So if that did not answer your question adequately, Joe, feel free to reach out to me separately and I'd be happy to address that more, or perhaps through Brian or one of the agency staff, and we can work through it. Any other questions?
Yeah, Tony, this is Eric Cannon. I mean, there are people that are part of this board, for example, Neil, and others that I conduct business with that are outside of the purview of this committee or this meeting, and so you know we're talking about business between the two of us that involve his company and my company. You know, your comment about text messages, emails, you know, communication between board members. To what degree is that a public communication, or could be, you know, so to speak, discoverable? And I guess, what advice do you have to those of us that maybe engage in business that is outside of this committee, in terms of, you know, our maintaining things so that they're at an appropriate level.
Eric, good question. The rule of thumb is that anytime you are engaged in private business that is not involving the government's business, then those messages typically would be considered private, and there are other laws dealing with the protection of those types of communications. My comments are directed towards the government's business. So, for example, if there was an agenda item and that agenda item was published a week before, individuals of the board reviewed that particular agenda item, and then members of the board contacted, a member of the board contacted another member of the board to discuss that particular item. That is where a line perhaps could be approached or perhaps even crossed as far as violating the Open and Public Meetings Act. So the rule of thumb is if you're acting in the official capacity as a board member, which typically primarily occurs during board meetings, there are limited circumstances under which it would occur outside of board meetings. But if you are discussing government business because you are a board member with another member of the board, that typically is something that would need to be presented, preserved for the public's review. Now, having said that, there are a lot of factual details that could perhaps create safety zones that would need to be discussed separately. I think the important thing to remember, anytime you're acting in the official capacity, whether it be personal email, text, or wherever, that could be scrutinized. Now, obviously, there has to be a reason for someone to request it. Someone would have to submit a records request for that. And had that occurred, that documentation could be provided. And just because it's on your private phone doesn't shield it. The most recent example, and this is becoming somewhat dated, our former two attorney generals had all of their private phones and electronic devices scoured as part of the investigations, which charges were later dropped or they were acquitted of. But nonetheless, their entire public electronic device realm was violated by the need to know what government business was conducted on their public devices. So I hope that was a long way to say that, number one, keep your private business separate. And if you have private business dealings between board members, that's fine. If you are talking about the government business, primarily issues that are in front of the board or should be in front of the board, that is where you want to be extremely careful. And it's the same thing if you have a by chance meeting with a board member. Maybe you're in the grocery store picking up groceries. Keep in mind, if it's the government's business, oftentimes those discussions are best held, preserved, and presented during the board meeting rather than in public offshoot meetings where it could be viewed as a board member is attempting to sway the public body that could be or could not be for one's own public interest. Eric, did that address your question?
Yeah, no, I think that's perfect and well explained. So thank you.
Thank you. Well, if there's no other questions, I will excuse myself and let the board members get on to your government business. But again, thank you for your time and attention, and thank you for your service to the citizens of this state. Goodbye.
Thank you.
Thanks, Tony.
So we had a question in the chat about who seconded the motion for the approval of the minutes. Who was that?
I did verbally, Michelle Hoffman.
Okay, thank you. All right, great. So next item on the agenda is the Review Medicaid drug utilization and utilization management.
Okay, so what the team and I decided to bring to you today was something we haven't reviewed with you in the past, but we thought it would be helpful and also add rigor to our pharmacy program to present to the board utilization data over a year of time to help you understand which claims are being filled by Medicaid members from the pharmacy side. These are claims that are going through the point of sale system. And we have two different reports we'd like to review with you. And I'm wondering if Andrea's gonna, maybe she's working on pulling it up here. But the first report we'd like to go through, so just to give you kind of a overview of what we're hoping to accomplish with this, is the first report we're looking at is utilization data by cost. And so over the course of a year, we're going to look at the top 20 medications that are filled by cost to the Medicaid program. And then the second report looks exactly the same, but it is by claim count. Okay. I think what you're see, what this report looks at, what I'd like the board to weigh in on is, as we look at the medications, and some of the medicines we're looking at are focused on a drug specifically, and some have lumped multiple medications together. So we're not breaking it down to 5 milligram, 10 milligram. So we're looking at multiple doses of the same medicine. But if we look at the drugs, for example, and just to orient you to the table that's presented here, first of all, this is the top 20 drugs, the amount paid by the fiscal year 2019. So our fiscal year is July 1 to June 30th. And we're looking over the course of a year. And if we look on our top drug, for example, is an antipsychotic, antimanic, Invega, Sustenna, Intrinsa. So we put both formulations here, and that was defined. We have the generic name next. And then what we wanted the board to think about and help us identify gaps or opportunities was edits that we have, either pro-DURB first, so before the claim, as the claim is processing, these are called prospective DUR edits that will hit that claim to kind of control utilization. We do have a tab listing, is this drug in a 90-day supply program? So the 90-day supply program, as a reminder, is for certain chronic medicines. If a patient were to receive 2 consecutive prescriptions for the same dose, it will autofill as a 3-month supply on that third fill. And this was meant to be a cost-saving measure, but also a way to improve adherence by giving a greater quantity. And then the next tab is looking at retro-DURB, utilization management. And then for a select few drugs, we have additional information noted in the final tab. So in the spirit of using our time here as productively as possible, we had hoped that we could just kind of move through and we can go drug by drug. But what we also want to know, want you to identify as well, is that many of the medicines we're looking at are carve-out medicines. So they represent utilization for the entire Medicaid program, okay? So we can note that as well, which might be why, of course, if we're looking at not just the cost, you might think, oh, fee for service. Well, number one, number two, all of our mental health medicines have been carved out. MAT is carved out. So I'll just touch on that. We didn't include it on the graph, but part of why it ends up in the high cost category is because it also represents utilization for our entire Medicaid population. So pharmacy team, please step in here where I need to add any more description or granularity just for the overview and or as we're going through. So one of the things, like, we'll just start at the top and work through here. But I think what we're hoping for is ask questions, help us understand where we may optimize management. You'll notice that in many of the medicines that are actually on this list, we've covered them recently. So for the board members who've been with us for a year or a little bit longer, you'll note that last year we covered antipsychotics a lot because we were building our policy specifically around antipsychotics in children. There's also work going on the use of antipsychotics in adults. So let's just walk through and touch on some of these because they'll broadly apply to many of the classes. But as we look at Invega specifically, this drug does have a quantity limit edit. Brian or Joe or Yoon, help me, remind me here where the quantity limits are because I don't have a cheat sheet next to me. But we're looking at someone getting one dose every, whether that's 1 month or 3 months. These drugs can often be billed at the point of sale for a 1-day supply because it's a 1-day dose. And what we're looking at here is to make sure that they're filled at the right frequency based on the administration. So that's where the quantity limits are set. So for Trinza, you would not get an injection of Trinza, and that would be administered. And we give a window so that a person can come in like a week early or whatever, but it hits that 80% refill edit. But the quantity limits are set. What's that?
A lot of that too is to encourage appropriate billing.
Right.
You know, when someone bills for a 1-day supply, in all likelihood, it's going to be filled again 3 months later when it's due, but we still want that to be billed appropriately. And so putting those edits in place can help encourage appropriate billing.
The other piece of this too is that it hits other edits in our system that look at just flags for appropriateness and claims on the rebate side. So it also helps for other purposes as well. But clinically speaking, there's a quantity limit. And then of course, we put age edits in, I think about a year ago as well, looking at FDA labeling and making sure these are used in the right patient population age-wise. And then retro-DURB antipsychotic work has been focused on our peer-to-peer work. So we're looking at using multiple antipsychotics in children less than 20 years of age, metabolic monitoring. But I'll also say that part of the Support Act, there is work being done on concurrent use of antipsychotics and opioids. And that is retro DUR work done by the University of Utah, where it will trigger patients who are getting antipsychotics and opioids for more than 30 days at a time. And it will trigger a letter to providers educating about the sedative effects, which is what CMS kind of said they were concerned about with the concurrent use of these. But it's also identifying adherence to the antipsychotic itself. So there was an opportunity to look at the PDC or the adherence indicator as far as if there are gaps in picking this up and encouraging the provider, letting them know that the patient has been non-adherent to this. And of course, these are administered. The number one is administered. So, but on oral agents, really looking for opportunities to become adherent to the antipsychotic. So that kind of covers number 1 and number 2. And then please speak up, board, anytime you're seeing something or identifying an opportunity. On our ADHD medications, we're just walking into our edits for our ADHD medications for methylphenidate. Again, we have it listed here. These edits just went live, the age edits. And then there is robust peer-to-peer work being done by the pharmacy team, our pharmacy team, where we look at, before the edits are implemented, we'll outreach to the providers, educate them, and work with them on any patient who would trigger that would hit this edit. Next, we have pregabalin, and we know we discussed gabapentin and pregabalin a couple months ago as well, implementing safety edits around high dose and also concurrent use of these medicines. So we have concurrent use, we have high dose of pregabalin also in place and monitoring that product. That also hits an 85% refill limit. It's a controlled substance, so it's hitting that at the point of sale. If we move down, then we're looking at MAT and medications. These are looked at, we kind of lump them together in this drug category is our 5th highest. Suboxone for brand is required. There is no PA on that. There used to be, but as part of the Support Act and opening up access to all MAT products, the PA was removed on Suboxone. Other products, however, do require a PA because of their non-preferred status. There are also monthly quantity limits on using it. So we looked at this as a DUR board. We looked at multiple items, and we actually inquired with you around the use of buprenorphine, and we are also looking at implementing an edit just in the future on concurrent use of MAT and opioids together, by the way, in October. Our 6th highest cost category is the drug Mavorette. So the one piece with Mavorette is we have steadily modified the PA criteria. And I think over time we've brought the PA to you. We really want to open up access. We've worked with our public health partners on really promoting Hep C therapies for those that have been diagnosed, and we want to make sure they have ready access to treatment. We removed actually a lot of some of the laboratory requirements for the use of Mavorette on the PA form earlier this year. And then we launched a Hep C monitoring program for patients who are given a PA for Mavorette or any Hep C medication. The pharmacy team, the pharmacist will outreach to the patient when this drug goes through a PA process, and as they start therapy, and talk to them about adherence and help them understand if there's any questions about the drug clinically, any side effects or barriers are identified to taking the medicine. And then our technician team will follow up with the patient throughout the duration of therapy to hope to improve our rates of treatment success. That was launched April 1st of this year. And I think we've had just over 50 patients in that program. And many have completed therapy so far. Any questions? Okay. Next is Vyvanse. This I think lumps into other ADHD medications. Moving down to 8. Again, this is an antipsychotic, so we're looking at aripiprazole. This is a drug for age edits is less than 6 years of age, so that age edit is not 4, but is actually at 6 years of age, and similar alignment with our, well, exact same alignment with our other antipsychotic outreach. For number 9, again, this is another antipsychotic. Andrea, would you scroll just a little bit?
And one thing that I think might be worth noting too on some of these drugs is, in some cases, these are drugs that have a very high pharmacy reimbursement and not as high of utilization, and others are drugs that the cost of the drug is maybe more moderate, but there's much higher utilization.
Yeah. So I think Brian, speaking to number 9, Vraylar is non-preferred, correct, Brian?
It is non-preferred, and the same thing would apply to Mavorette, which is, the Hep C drugs are very expensive drugs, so we're not seeing as many Mavorette prescriptions as we are aripiprazole. But yeah, that also applies to Vraylar and some of the others.
I do have a question. Does Utah Code Title 26, Chapter 18, Part 1, Section 2.4, Subsection 3, in which healthcare providers can override and write dispenses written still in place such that really any preferred versus non-preferred is kind of mute in terms of the 5 classes of or 5 classes of psychotropic medications?
Yes, that is still the case, that dispenses written can override the non-preferred status on mental health drugs. And so that's one of the challenges that we have, is it makes it more difficult to manage mental health medications.
Good question, by the way, and I think a good point as well is that while we can create preferred and non-preferred, it's kind of a soft stop that that can be overridden by placing dispenses written or putting a DAW1 on the pharmacy claim when it's processed because the prescriber wrote dispenses written on the face of the prescription.
And Sharon, you had a question about seeing things in the community frequently. Are you referring to the prescribing of antipsychotics and the use of DAW1? Yes, we do see quite a bit of that, especially on the non-preferred antipsychotics. We see a lot of use of DAW1 as opposed to going through the PA process and having a trial and failure of a preferred product first. And incidentally, we also see it a lot in primary care and mid-level providers as opposed to psychiatrists and mental health specialists.
I did have a question with regard to the indication for use of some of these medications. The category you have, for example, for Invega, Sustaina, and Trinza is antipsychotic / anti-manic agent. Do you ever look at, or are you able to look at whether these medications are being used off-label for bipolar disorder? Because Invega Sustaina is only for schizophrenia and schizoaffective disorder. Trinza is only for schizophrenia.
It's difficult to accurately assess that information because we're looking at claims data, and a pharmacy may or may not submit a diagnosis on a claim, and what is submitted on the claim may or may not be accurate. We haven't done a deep dive in comparing diagnosis codes that are submitted for reimbursement from the provider and linking those, and that poses other problems as well.
Brian, I'm sorry to interrupt, but if you recall, when we did our work in children last year, we required a diagnosis code on claims for antipsychotics in children, and we intentionally did not limit what that diagnosis code should be. We allowed any diagnosis code, but it does require a diagnosis code. It's been just about a year since we implemented that edit, I believe. Maybe it was October that we implemented that edit. And at that point in time, we'll query the data and look to see, by different age category, because I don't think it's a requirement in adults. I think it's a requirement just in children. And we were specifically looking at what the drugs were used for.
I only make
and just in antipsychotics currently.
Right.
I only make that comment because that also may drive up cost and utilization for off-label uses that may or may not be appropriate. And having worked on this particular part of the Utah code in developing the database, I know that linking diagnoses really is not feasible at this time. So that is something else that you need to keep in mind as to why so many of these medications that are high cost or, listed as, those that fall under psychotropic drugs.
Okay. Let's see. Number 10, we're moving into a different class here that is not a carve-out medicine, and it's actually Humira. And so we have Humira is preferred. It doesn't have restrictions on our PDL, but it is used an awful lot. So that would show up as our 10 most costly medicine filled through the point of sale system. And number 11, we're moving into hemophilia. So I believe at last update, there were 32 hemophilia members filling through the Medicaid program. This medicine is a carve out. Hemlibra, we will be looking at the prior authorization criteria here. If we have time today, we'll be touching on that, but it was recently updated. But we're seeing use in a few hemophilia patients with that. And then as a note with Hemlibra, well, we'll touch on it when we get to the PA. So let me just move through this. I'm kind of looking at the time and want to make sure that our review is valuable and not just we're saying everything just to make sure I'm saying it. But we have a Hep C medicine next, Epclusa. Again, follows the same criteria with a prior auth, but with our Hep C adherence program in place, looking at finishing treatment the first time someone receives it, or at least when they're prescribed a course of therapy. Number 14, we're looking again at an injectable antipsychotic. And then we move into Vimpat. And this has no restrictions on it. It's a preferred product. We have a lot of use of Vivitrol. And as line number 16, Vivitrol runs through both the point of sale system and also our medical management. As we know, it's administered in providers' offices as well. So we permit that administration as well. This represents only utilization on the point of sale side. So this doesn't even tell us the whole picture because this is simply looking at point of sale utilization. One of the challenges we're having right now with this, we have a kind of retro-DURB oversight of this. We're looking at adherence rates to MAT over time, and Vivitrol is not exactly where we want it to be. There's a lot of one and dones with Vivitrol where patients get one injection and then do not get a secondary follow-up. And that's something that we are working with it's a prepaid mental health plans and things like that to really look at how we can address adherence to all of our MAT products. But that is not in place at this time. 17, we're looking at hemophilia again, multiple products line into this. These are really high cost drugs, but we evaluate these as part of our hemophilia treatment program. We have a program in place. We're evaluating the prescribed dose, and when a person picks that up, we're trying to promote adherence to the medicines. We work with the hemophilia treatment centers when we identify early fills for bleeding episodes and coordinating care with them. So they are part of that picture. And the fee-for-service team is actively working with the treatment center. We just had a meeting with them this week, actually looking at care coordination and different elements of that service. 18th is Lantus. We also have other products in here for diabetes. We have quantity limits on this, just again, looking at dosing of this. And then we have our preferred products in place. But overall, minimal, robust management of these products. But we have open access to many of them. For line 19, we're looking back at ADHD medications and then finishing up with anticonvulsants. Multiple brands are in this category. Looking at this, and we have preferred and not preferred products, but no pro-DURB or retro-DURB edits in place to manage these.
Hey,
Are there any questions, comments? Go ahead.
yeah. Can we put that last one on the agenda? Because it looks like we've reviewed other agents that are used for the same indication in the last couple of years, but I couldn't see where we've looked at this one at all, at least since I've been on the board.
Sure.
By last one, are you referring to the anticonvulsants?
The Gabatrin.
Okay.
Yep.
You should be aware that this medication is restricted by a program called the SHARE program, in which the prescriber, patient, and pharmacy must be enrolled because of the severe potential adverse effects of the medication.
Right.
And if it is not effective, it has to be, it's recommended discontinuation within 3 months.
Yeah, maybe we could see how it's being utilized as part of that, but yeah, definitely.
We can try to, let's run through the top drugs by claim count and we'll see if there's any further discussion. I'm sure we mentioned this before, and when these drugs, when we presented pregabalin and gabapentin, but gabapentin is a carve-out medicine. So this represents all of our Medicaid population when we look at these claims. And we included claim count here so you could see. We didn't do that with the others because it was by cost. But here by claim count, gabapentin tops the list. It's the #1 drug filled for Medicaid recipients. You know that we evaluated this, I believe, in January of this past year. And we created, again, concurrent use with gabapentin, pregabalin criteria so that it's restricted and not being used together. We also put an upper dose quantity limit on this. And that is as far as we've gone at this time with managing gabapentin claims within the system. Next up are our ADHD medications, another carve out. Next, and again, we covered these edits, so I'm not going to go into them again because we've touched on them with the other list. What's next on the list is trazodone as third most commonly filled medicine. And there is a 90-day edit on this drug when it's used chronically. And as we know, it's most commonly probably used for sleep. Our fourth most common drug filled is the antidepressant sertraline. And 90-day supply edit. Next, we clumped many antidepressants together underneath the bupropion class. So we're looking at the different formulations of bupropion. And we have a PA for the non-preferred formulation of bupropion of the Forveo. Next is antidepressant fluoxetine. And then we hit our benzodiazepines. So clonazepam, we do have a PA in place. As you know, we covered concurrent use of benzodiazepines and long-acting opioids. There is also so that is a hard stop at the pharmacy, and it requires a PA for any benzodiazepine used with a long-acting opioid. Short-acting opioids and benzodiazepines will trigger we call DUR. Our system calls it a hard edit, but the pharmacist is required to put a DUR override code in the system saying they spoke with the patient, they spoke with the provider, and it has a limited use of what it is they're saying that they used, whether they spoke with the provider or the patient, so we kind of limit what they're allowed to put in. And then it also has a message prompt on the impact of respiratory depression that is seen with this. So that DUR message will show up when any short-acting opioid is filled with a benzo. In addition, we don't have RetroDur noted, but Mo has actually been doing peer-to-peer outreach to pharmacies. So when we identify high fill pharmacies with this combination of short-acting opioids and benzos, Mo has developed a slide deck in conjunction with Doppel. And the Doppel team has been going out and doing work around using the controlled substance database. And Mo is encouraging looking at the controlled substance database and also educating on what our Medicaid edits look like, and also the risk of respiratory depression, and encouraging the pharmacists to talk to their patients, asking what they're talking to them about. And then in addition to this, encouraging the use of naloxone. and prescribing naloxone when this combination is filled together. So that was part of the work that Mo has done continuously in the time that he's been here. Next up is methylphenidate, and we've talked about methylphenidate edits, so we won't go further into that. Next is, after that, is quetiapine, aripiprazole. Again, we're seeing a lot of our carve-out medicines as our top filled by volume. So maybe no surprise that our population has a lot of mental health meds on board. And then next up, I'm not seeing the numbers on this. I don't think the numbers on the left of the screen are actually representing our top drugs, because I think the numbering's off a little bit. But we're looking at buprenorphine. And this is kind of, again, putting our buprenorphine products together. Next up is alprazolam, lamotrigine. And you can see the 90-day supplies hitting for some of our chronic medicines that are lower cost and available generically. Next up is duloxetine, escitalopram, Vyvanse. Sorry, I feel like I'm just kind of reading here, but we can see moving out of the mental health class of medications, then we have our medicines used for asthma, so albuterol, levothyroxine. One thing on albuterol I do want to note is that we do have, sorry for the typo there, is that we had some shifts in availability with COVID. There were limitations in availability for some of our formulations. So we did open up more access because of that. And wanted to make sure we were addressing any access to care with that. It was also, I believe, on some of our, well, not albuterol, but some of our other inhalers were on the 90-day supply list, which we took off because of supply. Levothyroxine is coming up with, I think, number 18 on the list. Number 19 is divalproex. And then last is citalopram. Are there any points for discussion on top claims by volume and the edits that are in place? Are there any recommendations or spots where we may consider approaching retro or ProDUR edits differently, or where we're missing things? Okay. I don't know that this requires a motion because there haven't been any recommendations. But thank you for your patience with going through that. I would like to actually just ask the board, was this helpful and meaningful to bring to the board? So you can see what the population is using. And okay, Dr. Weinstein says yes.
Yeah.
And to see how we're managing these.
Jen, this is Michelle. I think it was really helpful. It was educational for me. I was just simultaneously just trying to understand if these are unique patterns in our state, but they're not. Just reading a policy brief from California, looks almost identical in terms of the patterns of utilization and cost of the strategies. So I think it seems like you guys are, really ahead of the curve in terms of implementing all of the strategies for cost and utilization management pretty comprehensively.
Thank you. Well, you can see much of it is recent. So it's interesting because I don't know that we've actually routinely evaluated this list. I think we should make it annual. It doesn't need to be this long, exhaustive process, but annually we should probably bring this to you and make sure that we're looking at claims and making sure we're evaluating our program for the rigor that we have and finding gaps. But it's interesting, as we were going through this as a team, we're like, wow, it naturally, like we were doing the right kind of work in bringing these topics, because I don't think we started from here and then decided to review these topics. We reviewed the topics because they made sense to us. We knew we had gaps in our policy and we needed to make it more robust. And so then we pulled utilization, later, and we're like, Because we actually, in our current system, we don't have generated reports that looks at this, that are really user accessible. So anyway, thank you for that feedback.
Yeah, and just one other comment, which I think in order to like kind of take it to the next level, I'm wondering how we can improve. I just wonder if there's an ability to do a little bit more demographic stratification around age and comorbid conditions, especially disabilities. I think that might help you target interventions a bit more in a more sophisticated way to actually make them.
And we have diagnoses there, and we're not unable to pull diagnostic. Like, I mean, I think even like to your point, Dr. Hoffman, I think I would take back a proposal of how you might want that looked at by class. And I think it could be meaningful. We've had that when we've looked at antipsychotic utilization, even going by category of aid, sometimes helps us. We've done a lot of work to determine foster versus non-foster care. And are those patterns of use different? Or we can look at different populations by category of aid or by age even. So, we are open to proposals in the future of how you may want us to slice and dice it, and evaluate it by more, by a deeper dive. So,
and I'm wondering too, if in the future, just knowing about our state and some of the unique aspects of being essentially a frontier state, if at some point some of that geographic data of are we seeing patterns in certain areas of the state, knowing that we have constellations of experts in certain areas and not others, is that impacting prescribing patterns and costs, and would allow for more targeted education?
Yeah, I mean, they're all excellent. Yeah, rural pop. I mean, I agree with you. It's we're finding. I mean, we've discussed this in smaller groups, right? About what the prescribing looks like and how we could educate some of our providers in the more rural areas, and help optimize care through those interventions. But yeah, we're up for any recommendations the board would have. We'd be happy to dive deeper into any of these drug class areas. And it is almost that, we're coming up in the next few months on the 1-year mark for our antipsychotics in children. And so I think we'll review that at that time as well and look at where those quality measures come in. Because we're measuring quality measures for many of these on opioids and antipsychotics in children where they're published. HEDIS measures or PQA measures. So, yeah, I'm seeing the comments. We'll capture all the comments, Dr. Weinstein. Thank you for giving them. So with that, we only have 4 minutes left. We had a couple other agenda items. If there is no more, sorry, Catherine, I'm stepping in here. We had some PA forms. We had some updates to the Hemlibra PA. We wanted to run by the board, and I'd like to just quickly show this to you if we could. If I could hop to that item. We met with the hemophilia treatment centers, both from Intermountain and the university this week, had a really great conversation around gene therapy, which is on the horizon, talking about Hemlibra, and then also our case management services, which have been distributed out to the plans. And it was a really productive conversation. But at the time, they had some recommendations to modify the Hemlibra PA form. And we wanted to bring their recommendations and the additions to the form, modifications to the board just for review. But just to let you know, the experts have reviewed this. And if as Andrea is pulling it up here, the main separation on this form and the update had to do with the new indication for Hemlibra. And the one thing I found is when we talked to them, when Hemlibra came out, and I don't know, just over a year ago, there was concern about which patients to use this in. And I'll try to be really fast here, but we know, like, first it was indicated for patients with hemophilia who had sorry, I'm trying to move up here, with inhibitors. And they were requiring really, really high doses of their factor. And with that, they were kind of resistant to their factor, requiring high doses, having bleeds, and Hemlibra seemed like the ideal patient for them. However, we didn't see every high dose factor patient being switched over. And I think at that time the drug was new and they weren't quite ready. They were going to introduce it to one patient very selectively at a time. And
Looks like Jen froze.
Uh-oh. Yeah. Let's see if we can get her back here.
I just texted her to let her know.
Okay. Thanks. We'll give it a minute, so hopefully we can get her back so she can finish her thought there.
While we're waiting on Jen, does anyone have any comments or questions or thoughts on Hemlibra?
I mean, Brian, I guess the one question I've got is, and I think one of the things we struggle with in looking at all of these factor products is you've got a maintenance dose, but then you've also got an acute dose or potential for an acute dose that goes on top of that. Yeah, and I always struggle with this as I look at these because it always feels to me like the pharmacy is, in addition to that kind of prophylactic dose that they're getting, they're pushing that acute dose, kind of that emergency dose to the maximum, and they're filling it for that maximum dose every month, even though we all know they're not dosing with that acute dose every month. And so you find yourself in a situation where you're trying to understand how much stockpiling is going on, how much, what are the other things that are happening kind of behind the scenes. And I think the factor community is very tight knit, and we have run into a significant number of schemes where people are stockpiling factor and then they trade that with other factor patients, and I'm not discounting, I guess, the need for patients to be able to have access to drug. Mm-hmm. And at the same time, it really feels to me at many times that we're giving these patients on a monthly basis way more drug than they actually need. And I don't know that I've got a good answer for this. And it's still a huge concern. It's still something that drives significant cost.
And I think with these drugs, it becomes increasingly important to have those communications with the hemophilia treatment centers and make sure that there's an understanding of, okay, if someone is getting a lot of bleed doses, okay, let's find out why that is. Do we need to increase the prophylactic dose? Is there, things going on that can be mitigated? Hemlibra, I think, is a very valuable drug because we've seen in a lot of cases where it has decreased the number of bleeds and decreased the use of bleed doses. But again, is it appropriate to be using in someone who's got mild or moderate factor VIII deficiency, or should it be reserved for the more severe patients and those with inhibitors?
Yeah, no, and I think the key, you just hit on it, is kind of having a pharmacist or someone who's communicating with the hemophilia treatment center and coordinating back with the pharmacy, because you want to take care of the patient. You want to make sure the patient has access to the right amount of drug, and at the same time, how do you guard against kind of this overuse stockpiling that I think happens. And I don't know that I would do anything different if I was a patient. I mean, I think, making sure that I've always got enough drug on hand is going to be paramount to what I'm trying to do. And so, what is that appropriate management, and how do we as a state guarantee that kind of and ultimately it comes down to coordination, I think, between your team and the pharmacy and the hemophilia treatment center. So, and it sounds to me like you guys have got those kind of protections and that stuff in place. So,
yeah, and we do have close communication with the hemophilia treatment center, and we review the claims monthly, and so that's things that we're trying to do on our end to try to ensure that these patients are getting the best care that they need without, like you said, having more medicine than they need. We don't want someone to stockpile more medicine than they need, and then for whatever reason they get switched to a different factor, and then they're left with $500,000 of drug that is of no use to them.
Right. Well, in the interest of time, can we bring this back next month?
Yeah, Jen got kicked off the VPN and she can't get back on. So she suggested we bring it back next month.
Okay. Sounds good. All
I'm
right.
just surprised Neil doesn't have like Netflix playing on that big TV behind him. I mean, the real question I've got is, how much time does he spend looking at the computer, turning around and watching Netflix on the big TV?
That's not a television. That's my whiteboard. That's my working whiteboard. It looks like a television. It is. It's a blackboard, dry erase board. That I wish it was a television that size. That'd be pretty awesome. But no, that's for me to try to keep my thoughts straight.
Okay. Sorry.
All right.
No,
I tried a huge whiteboard, but it just made it even worse.
it does. I'm finding the same thing. It just makes me stress about it more.
To try a million sticky notes, then we're in a beautiful mind. Oh God.
Although Michelle's got her whiteboard up, I mean, I can see her whiteboard back there. So,
Yep.
Good
I'm
stuff.
I'm in my office at work.
Great minds think alike, right?
Absolutely.
yeah, well, my staff, I've got 3 people that work for me that are still trying to figure out where their whiteboards went that were in their cubicles, that they have no idea they're actually in my office at home now. I understand the whiteboard.
We won't tell on you.
Yeah, they'll figure it out eventually.
Funny.
Well, there's. I mean, I'm not an expert with this management condition management strategies for this condition, but I suppose there's no way to dispense drug to the treatment facility, right? If you have a group of, I mean, I was just trying to figure out how to get around the drug sharing. Drug sharing and is a common thing, and with opioids, people are obviously quite concerned about it. But I was just thinking, if you had a treatment center and a pharmacy, and you're talking about having some reserve of drug for episodes or something like that, and we could bring this back for discussion, but not being in this clinical area, I was just wondering, maybe people could think about it and the pharmacists could think about it. Is there a way to have a reserve of drug at the treatment center where rather than dispensing it, one at a time, so to speak. So something to consider as a way to conserve the supply, especially where you have such a high cost item. I don't know.
Yeah.
Well, what's typically done, at least among our patients, is patients can have their prophylactic dose dispensed regularly, and then they'll also get a bleed dose to have on hand. And then if they need to use that bleed dose, then they can get a new one to replace that. And those are IV infusions, but those are typically done in the home. Hemlibra is much easier for patients. It's subcutaneous.
Mhm.
Again, in the interest of time, it's probably best if we
Gotcha.
wrap things up and
Yeah.
pick it up next time. But
Thank you.
it is
Yes.
a fascinating topic, I think.
Agree. Yeah, please keep your ideas and stuff for our next meeting, because we'll want to hit this one when we meet again in August. So, yeah, we're well past the time to adjourn. Is there a motion to adjourn the meeting?
Move to adjourn.
Is there a second?
Kumar, second.
Second from Kumar. All in favor?
Aye.
Aye. All right, thank you.
Thanks. Bye-bye, everyone.
Next